My name is Johnny Delashaw, and I'm one of the faculty here at Swedish Neuroscience Institute. I'm a neurosurgeon that is interested in skull-based surgery and fly fishing. And I've been asked to give a talk for the group, and today I would like to give a talk on orbital and cavernous sinus anatomy. And probably due to the sake of time, as far as surgery is concerned, we probably will not get very far, and we can do that at another time. We'll just see how it goes. I have 30 minutes. Is that correct?
More or less.
Okay. So let's just move on. And for the fellows, I'm going to ask you lots of questions, so you got to pay attention. But before I actually give the lecture, I do want to make an announcement. There is an opening. This is business now. There's an opening for a neurosurgeon at Providence of Everett, which is part of us. And if any of the fellows are interested in that potential position, it's general neurosurgery, please let me know. And if any of you all have someone else you know that might be interested in that position, please let me know. We're actively recruiting at this time. All right, so we'll move on with the talk. So I have a disclosure. It says here, this talk was done at Tulane last year as a visiting professor. And the disclosure's a little inaccurate. I'm a consultant for Integra, but I haven't received any funds from Integra for 6 years. So I'm not sure how much of a consultant I am. But I am a consultant for Synaptive, particularly with the discussion of their imaging device in the OR. I'm an avid fly fisherman, and please interrupt or ask questions. The only stupid question to ask is whether to fish or not to fish. Okay, we all know what the answer to that question is. So there's some basic principles for the neurosurgeon regarding skull-based surgery, and the first one is if you want to be a safe and efficient skull-based surgeon, you need to know your anatomy. And you all, the fellows, actually, and the faculty, have an opportunity here. Unlike a lot of places, we have a skull-based lab. And you all, if you're really interested in doing this, should spend some time in the lab going over anatomy, particularly how to get there, a surgical approach. You're not going to get that opportunity as you move forward. Very unlikely. And you can't make a mistake in the lab. You can in the operating room. And it will markedly affect your confidence and how well you can handle a difficult problem. With skull-based surgery, there are a number of operations that have been written about and proposed. And I think it's real important that each lesion, you have to kind of think about where it is and tailor your craniotomy to the problem. That there isn't one operation that fixes all. And skull-based surgery for a long time was very, very interested in removal of bone. Removal of bone seemed to be the answer. The more bone I can remove, the better vision I have, the safer the surgery is. Well, that's probably true in some respect, but opening and dissecting up the CSF cisterns to maximize exposure is far more important than how much bone we remove. And it not only does it let you see more, but it reduces brain retraction. So, and that's interesting because that actually was pounded on me as a resident from somebody the fellows may never heard of called Yasirgil, famous neurosurgeon from Turkey who was in Switzerland. But that was his thing, and it's proven to be time and time again far more important than bone removal. So as I give this talk, particularly for the fellows, they need to really pay attention to the fish slides, okay? Because I'm expecting you all to tell me what the fish are. And not only that is we're sort of changing themes about where we're headed in the talk. So this is my cabin up at Alaska, and this is a picture of my neighbor right here. This is my neighbor. He comes by and visits along with a lot of his clan, and therefore I usually carry a .44 Magnum with me. And this is in the winter. This is in March. This is my son here, and the Iditarod comes right in front of the cabin. This is the Iditarod race. There's usually 70 individuals racing in that, and it's basically an excuse to go up in the winter on a snowmobile, have a big fire on the river. There's like 4 feet of ice, but have a big fire right on the river. You think it might melt through, but it doesn't, and drink a lot. That's really what the Iditarod's about. Okay, so, and for here, let's see. Raghu, what is that right there? Besides a happy fisherman, what is that? Caught on a fly rod. Anybody know? That tell?
Copper River Red.
Well, it's the Lake Creek is the river, so it's not a copper river, and it's not a red. So we're going to teach you a little bit about fishing. So this actually is a king salmon, okay, or also known as a Chinook, and they're the largest salmon that come up the river, and they tend to come up first. And after they come up and they spawn, the next group of fish that come up tend to be either the sockeye or reds, which come up in big droves, and they don't like to eat very much. You actually have to floss them. They don't really eat. And then the next group is usually a chum salmon, which is a larger salmon, also known as a dogfish, because the natives don't eat it. They feed it to the dogs. And then along with the chum come the pink salmon, which people don't really like to eat either. They're kind of a soft meat. The pink has a big hump on it, so it's also known as a humpy. They have taken over the world because nobody eats them, and they have multiplied. And actually on satellite, sometimes you can see literally thousands upon thousands upon thousands in the ocean or in a river from a satellite up in space. That's how many pink salmon there are these days. And then finally the silvers are all come up. They're also known as coho salmon. The coho, the sockeye, and the kings are the best eating. So those are and they come up, that's kind of the order they come up. And it starts in early June, and by end of August, the fish have all run up and they die. Now, one other thing about fish before we get too far in this is the sockeye are really interesting fish because are reds that you'd mentioned, because they don't go up every river. In order to have sockeye go up a river, there has to be a lake, and there has to be a creek or river flowing into the lake, and then an outflow that goes towards the ocean. And what happens is the sockeye go up the river through the lake to the creek, and they spawn. And then the fry come down and they sit in the lake for a year or more. Where all the other salmon, they get flushed down to the ocean. They sit in the lake for at least a year before they go out to the ocean. So if you have a river that is from the mountains and goes right towards the ocean, you will not see sockeye in that river. Okay, it's a very interesting fish. All right, so let's move on to what we came here for. So let's talk first about the orbit. So the orbit is shaped like a pear or an ice cream cone. And it's big wide out in the front where the globe is, and as it narrows down, there's several holes or foramen. If we look at the right orbit, what we see here is we see this big wide opening, and we can see some bones here. So first of all, this is the frontal bone, right? And there's a little notch or foramen here. It's a foramen where the supraorbital nerve and supraorbital artery run through. As we come down, here's the frontal zygomatic suture, and here's the zygoma, the maxillary bone, and it fuses very early. You don't usually see a suture, but with the palatine bone right here. And then this is the lacrimal bone and the ethmoid bone. And what is this here? Brian, Carter, what's this?
This wing is sphenoid.
Greater wing of the sphenoid, right. And in the greater wing of the sphenoid, there's some foramen. There's the inferior orbital fissure and the superior orbital fissure, as well as the optic canal. So if we look here a little bit more, we can see here's the superior orbital fissure, and what runs through the superior orbital fissure is the ocular motor nerve, the third nerve, the trochlear nerve, the sixth nerve, and the first division of the trigeminal nerve. What runs here is the optic canal, the optic nerve runs, and the ophthalmic artery, right? And here is the anterior and posterior ethmoidal foramen, where the anterior and posterior ethmoidal nerves run. This is important for skull base because if you kind of know where this is, it's actually farther back in the orbit than you might think at first. But these as they come up into the anterior fossa are the classic feeders for the olfactory groove meningioma. And if you get them early, the surgery to taking out the olfactory groove becomes much, much easier. So I'm not telling you to go in the orbit to get it, but this is where its location is, going up into the anterior fossa. Okay, so Odin, what's that? Perfect. That's exactly right. As a whole, I made, and you've seen this lecture before. Okay. All right. So if we look at the top of the orbit, there's the frontal bone, and this is the lesser wing of the sphenoid performing the anterior clinoid. And in older folks, the frontal bone may be absent in some places, making craniotomy easier when it's absent. But that's the, and the bumps on the anterior fossa are related to the sulci and gyri of the frontal lobes. If we look through and down on the floor of the orbit, we can see the infraorbital fissure, and there runs an infraorbital vein, which is not very important for surgery. We can see a groove here where the second division of the trigeminal nerve from the foramen rotundum comes up. Foramen rotundum's over here, comes up and goes over the surface there and runs through the infraorbital foramen and supplies the cheek. We can see the lesser wing of the sphenoid forming this thick, sort of tooth-like structure called the anterior clinoid, wherein just medial to it is the optic canal. Laterally is the sphenoid and the zygoma. Now, if you look at this is a slice of the orbit, and what's interesting about this is the right orbit. You can see that the frontal bone is pretty thin right here. That's going to help us when we do craniotomies. And we also see that the floor is very, very thin, where the maxillary sinus is. And, I think God was kind of thinking about this. So he was thinking about automobiles. So when you put your head through the windshield in an accident, this stuff is so soft, it's like a shock absorber. So we see lots of times infraorbital fractures, or in the medial wall is also quite thin. But back here where the optic nerve is, it's very thick and it protects the optic nerve. So optic canal fractures are not very common. They can occur, but they typically have a orbital, medial wall, or floor blowout fractures. And then finally, if we look at the back end, we can see the anterior clinoid here, along with the optic canal. And what's this called? Anybody know what that is? Optic strut, which connects basically the canal to the anterior clinoid. Now here, this is a little unusual. There's an extra fusion here, but here's where the carotid is, the internal carotid, supraorbital fissure, and the foramen rotundum. Here's the groove where the metameningeal artery is. Now, just so you guys this is kind of an important thing for surgery. It took me a long time to figure this out. The cranial nerves, 3, 4, V1, and 6 run through the supraorbital fissure, right? Here's the supraorbital fissure. But they don't run right up here. They're down here. Okay? They're down here and just underneath the anterior clinoid. And that's going to be important because it's going to help us do surgery if we get that far today, as far as how we can be a little bit more aggressive around the anterior clinoid and the supraorbital fissure. Okay. Anybody know what this is? Roosterfish. Yeah, it's a roosterfish done in the Cabo area. It's a really hard fighting fish. Okay. All right, so let's go through the anatomy of the orbit first. This is Dr. Litvak's patient, and he was kindly donated himself to us. I'm kidding on that. And what we're looking at here is we've taken the brain out, and we've cut the dura off, and we're looking at the frontal bone and the lesser wing of the sphenoid. Here's the olfactory nerve, right? And here's the optic nerve and the internal carotid. Now, the dura, as it comes up over the optic canal, forms a very thick dura, okay? And this thick band here is a problem for us. It's not a good thing. Because if we have, here's the pituitary gland. If we have a pituitary tumor that pushes up on the optic nerve, this thing can be quite thick and firm, and it can actually cause compression of the optic nerve there. And you can see sometimes an actual indentation related to this. Same with a large aneurysm, it can push up against this. What is this band called? What do people call this band? falciform ligament. So when you're doing surgery around the orbital apex, it's important to identify this, and I take a nerve hook and just kind of lift up underneath it over the side, not necessarily right over the optic nerve, but on the side here, and cut it. And it really frees the optic nerve and allows you a lot more mobility. In particular, it's much more difficult for much more easier for ophthalmic aneurysms or large intracranial pathology like large giant pituitary tumors or meningiomas. Okay, if we take off the roof of the orbit, what we see is a shining glassy membrane called the periorbita, right? And it's what's interesting about this is the pericranial tissue. You know, you have a scalp, you pull the scalp flap off, and you have pericranium over the skull, right? If you peel back that layer off the skull, it's contiguous with the periorbita. So as you peel back the pericranium, you come to the supraorbital rim, it becomes the periorbita. What's also interesting is the dura along the middle fossa floor is in two layers. And as it comes up to the supraorbital fissure, it splits, and one of the layers that comes and becomes the periorbita. So it's all contiguous. It's not separate structures. It's all contiguous. Okay? Here's another view of the falciform ligament. We've drilled out the canal, and here are the ethmoid air cells, just medial to it. All right? And remember, you guys can interrupt me at any time. Does anybody know what this is? You can look through here, and you can see some nerves. Does anybody know what that nerve is? Double D? What do you think it is? There's two double Ds, but the other one's gone. Okay. You know what that is? Trochlear nerve's right here. The trochlear nerve is the only motor nerve that runs outside the muscle cone. And here's the trochlear nerve going to the superior oblique. So it's right here. So what's this? Anybody know? Somebody said something. Somebody said frontal nerve. Correct. And if we cut the periorbita, and I like to cut the periorbita like this if I'm doing an orbital surgery, we can see the frontal nerve, and it will become the supratrochlear and supraorbital nerves that apply sensation to the forehead. And here's the lacrimal nerve going to the lacrimal gland. Now, I always thought it was interesting that the lacrimal nerve goes to the lacrimal gland. The lacrimal gland is lateral in the orbit, yet the lacrimal bone is medial. It's kind of interesting, you know. So if you look here, so we've taken out the fat. Fat's very cumbersome, and in surgery it makes it more difficult. You can see now, here's the trochlear nerve going to the superior oblique muscle, the frontal nerve becoming the supratrochlear nerve and the supraorbital nerves, and you can see the lacrimal nerve going to the lacrimal gland. Here's the lateral rectus muscle, right? And what's this muscle right here? Would you say, Christian? Superior rectus. Anybody want to argue with that? That's absolutely incorrect. What is it? What's on the top of the orbit? It's actually it's your landmark for orbital surgery. The levator palpebrae, right? It's the levator palpebrae that opens up the eyelid. Now, just underneath it and lateral to it is the superior rectus. Okay? Now, this muscle is a landmark for orbital surgery, and you're going to see why in just a second. So the levator palpebrae is on the top, okay? And when we do craniotomies where we crack the orbit and that kind of thing, sometimes you'll see patients have ptosis after surgery. They'll have ptosis for a while, it gets better. And I think it's related to trauma to the levator palpebrae, just taking the bone flap off. So this is a cartoon taken from a book many years ago by Shekar. And I really like this cartoon because it explains why that levator palpebrae is such a great landmark for orbital surgery. So we're looking at, from the front, the right orbit, and what you see is here's the optic nerve, and you see 6 of the 7 extraocular muscles come together and form connected by this band here called the annulus of Zen. Okay? 6 of the 7. What muscle is not part of the annulus of Zen? Raghu, you know? Inferior oblique. Not inferior oblique, I'm sorry. Inferior oblique, I'm sorry. Yeah, inferior oblique. So the annulus of Zen's here, and what it shows you is the following. One, it shows you the trochlear nerve, which we saw from above, right? It shows you the frontal nerve, and the lacrimal nerve. We saw those, didn't we? From above the levator palpebrae. And then there's the superior ophthalmic vein. They're all outside the annulus of Zen. Here's the superior rectus, and here's the levator palpebrae, more medial. So the reason why this is a landmark, if you're going after a lesion around the optic nerve, and you want to preserve cosmetic mobility of the eyeball and the ability for it to lift up, you want to stay medial to the levator palpebrae. If you stay medial to the levator palpebrae, you go right to the optic nerve. Does that make sense? Now, the ophthalmologists, they like to do surgery without neurosurgeons, right? That's what they like to do. But sometimes they ask the neurosurgeon to help them. But when they're going to try to do it on their own, they want to do orbital surgery. They don't want to go this way. I never have understood it. We can help them out. They come up, and they typically come in through a lateral orbitotomy, and they come up and they go over the top of the lateral rectus and go in this way towards an optic nerve lesion. Now, the problem with that is they run into the superior and inferior divisions of the oculomotor nerve, as well as the abducens nerve, and they get into a lot more cosmetic difficulty. And so, and here's the nasociliary nerve. We're going to see those in just a second. So really, this is a nicer option, at least for optic nerve lesions. Okay. All right. In this dissection, we cut the levator palpebrae here, and now we're looking at the superior rectus, and this frontal nerve just fell down on it. And what the important point is, do you see this little branch here? This is a little branch of the superior ocular motor branch. And what I'm trying to show you is that inside the muscle cone, the nerves line the muscles inside the inside belly. So when you're retracting the levator palpebrae and coming this way, you're even less likely to injure the nerves because they're lining the bellies of the muscle. Okay? So if you come in this way towards the optic nerve, you're going to have a much better shot than coming this way. There's the superior ophthalmic vein, there's the lacrimal nerve, but then there's the abducens nerve and the oculomotor nerves, and there's lots of stuff going on over there. Plus, there's a lot of fat. If we cut the superior rectus, we can see the superior division of the oculomotor nerve infiltrating the superior rectus muscle. And now you can see the optic nerve itself with the ophthalmic artery branching off into the anterior and posterior ephemoidal arteries. And it's quite a lot of stuff going here lateral to the optic nerve. Now the other, go ahead. It's inside the periorbita. Okay, remember on that slide quite a ways back, we could see the lacrimal nerve underneath the periorbita going towards something, which was the lacrimal gland. Okay? Now, everything in the orbit's confined by the periorbita. And remember, I told you I like to cut the periorbita in some kind of rational fashion. And the reason why that is if you do orbital surgery, you end up taking some of the fat, and then you take a mass out. And usually these patients have proptosis, where their eye is sticking out. But when you take the mass out, their eye wants to fall back in. And when it falls back in, if you don't close the periorbita, you don't have to close it watertight or anything. There's no CSF there. But if you don't close it, then the contents kind of just go bloop, and they have what's called inophthalmos. And instead of having proptosis, when they come back to clinic, now their eye is sunken in. So they don't look right either. So it's nice to put a few stitches in and kind of tuck things together, so that they stay in content. The other thing important to know is whenever you see a patient with proptosis and you decided to do surgery on them, for example, like a sphenoid wing meningioma that's causing proptosis, you really should counsel them that they're going to have double vision after surgery. And when you have a slow-growing tumor that pushes the orbit out, the globe out, the brain compensates, and they don't necessarily have double vision until it gets out of control. So if they have mild proptosis, they don't have double vision because the brain's compensated for that. The eyeball moves a little less, so they're still in sync. But when the surgeon comes in and takes all the tumor out and the globe falls back into normal position, the brain's not used to it. So they typically have transient diplopia, double vision, for a while until the brain kind of figures it out again. Does that make sense? So when you see a patient, you really want to counsel them that after surgery they're probably going to have double vision for a while. All right. If we go back to the orbital apex, we've cut the superior rectus and the levator palpebrae. we can see the superior division, again, innervating the inferior belly. But we can also see the trochlear nerve, and we can see, here's the third nerve coming up into the cerebral fissure, splitting off into this division. We can see the nasociliary nerve here. We can see the fourth nerve on the lateral wall of the cavernous sinus coming up here, and we can see V1, which is quite deeper, going up and becomes a frontal nerve as well as the sensory nerve to the eyeball. Okay. If we take out all the vessels, we can again see it gets pretty complex, particularly on the lateral side of the orbit. And here is the ciliary ganglion, okay, where the long ciliary nerves go up and infiltrate the pupil, okay? Sympathetic fibers, all right. So that's orbital anatomy. What's this? Actually, you know what this is. What is this? There are more rivers. Do you know there are more rivers in North America than the Copper River? So this is the Deschutes River in Oregon, and until about a year and a half ago, I owned a fly shop over there on the Deschutes River. And this is not far from Maupin. And this is taken years ago because I actually look halfway young, and this is taken that night in the evening, and I'm wearing my journal and neurosurgery hat that John Jane gave me, and I sent a picture to him. And this is a steelhead, okay. And the steelhead are trout that they go to the ocean. They get bigger. They come back up. They typically come out in two runs. There's a winter run and a summer run. What's interesting is the winter run comes up and then it hangs out until the spring, and the summer run does the same thing and hangs out till the spring. But and then they go up into little creeks and spawn. They kind of both spawn at the same time, and then the fry come down into the river, and they go down to the ocean by rainfall. So because they can't handle the current, so they sit in there, and then when there's a big rain, they get flushed down. And one last thing is about dams. People think the dams kill fish as they go up the river. They typically do not. They have ladders where the fish get pretty smart and they go up the ladders. But 9 out of 10 fry die going through the dams because they get flushed through the turbines as they're being flushed down. So only 10% of all the fish that spawn, that make it in the river, make it to the ocean. And so that's what's happened at the Columbia River. There were over 1 million salmon coming up that river, 50, 60 years ago. And now there are 100,000. And it has to do with flushing all these fish down the turbines. Okay. All right, so let's go over cavernous sinus real quickly, and then I think we can talk about surgical approaches another time. So if we look at this, Dr. Litvak's cadaver again, and we look from the top. We've cut the brain out. What we see is right in the middle, in what's called the sella, we see the pituitary stalk, right? And here's the superior hypophyseal artery, the optic nerve on each side. This is the right side, left side, and here's the internal carotid splitting up, and here's the middle cerebral. The anterior cerebral has been cut, and we can see here's the anterior cerebral right here. It's been cut. Here's the middle cerebral. We can see just below it is the third cranial nerve, right? And the third cranial nerve runs up and runs into the lateral wall of the cavernous sinus, up under the anterior clinoid, and as you had seen in the orbit. The fourth nerve, which actually enters the lateral wall of the cavernous sinus just behind the third nerve, actually runs, you can see it on the left side a little better, it runs along the incisura, right? Runs up, then dives into the lateral wall of the cavernous sinus. The sixth nerve, here's the sixth nerve. It actually is about mid-clivus, and here it runs into what's called Delashaw canal. Now, one thing that people sometimes don't understand is the sixth nerve is here, but Delashaw canal is up here. So what happens is the sixth nerve runs, it pierces through the dura, through the two layers of dura, and runs up the clivus, maybe 5, 6, 7 millimeters, and then enters the cavernous sinus through Delashaw canal. Now, why is that important? Well, that's important for a couple of reasons. If you're doing a very large acoustic tumor, and you see the sixth nerve, and you say, oh, it's okay, here it is, and then you take, you're bipolar and just start burning the heck out of the clivus here, you can cause a sixth nerve injury. Okay. Same way with a meningioma, like a petroclival meningioma. So you need to be a little cognizant that that nerve it doesn't just, as soon as you see it go into what looks like the clivus, it's running up a little bit before it goes into Delashaw canal. And then just underneath the incisura is the trigeminal nerve, which runs up and goes to the lateral wall of the cavernous sinus in what's called Meckel's cave. Okay. Here's a lateral picture of the same thing, a right optic nerve. Here's the internal carotid splitting off the anterior cerebral, middle cerebral, third nerve. You can see the fourth nerve running up along the incisura to go in the lateral wall of the cavernous sinus, and the sixth nerve. And you can see the trigeminal nerve here. What's this here? 7 and 8. And I always find it interesting how close everything is. It's a lot closer than you think, right? They're very, very close to each other. And when you see a large acoustic, sometimes the seventh nerve and the trigeminal nerve are stuck together by the tumor pushing up against it. So if you look at this cartoon, this is a picture of the right cavernous sinus behind the optic nerve. Here's the optic nerve. Here's the internal carotid. There's a thick dural ring, which we'll talk about in a second. But the point of this cartoon is that most of the nerves are in the lateral wall of the cavernous sinus, and they're surrounded by two layers of dura, a thick outer layer and a thin inner layer. And this is going to be really important when we talk about surgical approaches, because we can actually split the layers of dura and go into the cavernous sinus and do an entire cavernous sinus operation extradurally. And that makes a huge difference in recovery times. You know, hospitalizations 48 hours versus a big time, longer. If we look at this cartoon, here's the anterior clinoid, here's the internal carotid artery, the ophthalmic artery, superior epiphyseal artery. The third nerve comes up, runs in the lateral wall of the cavernous sinus, just underneath the anterior clinoid. The fourth nerve comes up, runs over the top of the third nerve, and runs over the levator palpebrae and dives into the superior oblique. We saw that on the orbital pictures. And then the first division of the trigeminal nerve all running through the superior orbital fissure. Just underneath it is the internal carotid artery. The internal carotid artery comes up right here. Here's the posterior segment. There's a bend here, posterior bend, becoming the horizontal segment, and then the anterior bend. And we'll see that in a minute. And remember, the sixth nerve runs just underneath V1, and it's the only cranial nerve that's inside the cavernous sinus. Okay? And this is Delashaw canal. Here's the meningeal hypophyseal trunk. So I'm just, for sake of time, we're going to move on to dissections, and then we'll quit for today. This is a dissection where we've taken out the lateral wall of the cavernous sinus. We've cut the optic nerve, and we've cut the falciform ligament and the optic nerve sheath. And what you can see here is you can see the internal carotid artery as it enters the subarachnoid space, with the superior hypophyseal artery going to the pituitary, right? And here's the ophthalmic artery. Now, the ophthalmic artery almost always is in the subarachnoid space, but I said almost always, okay? And it's somewhere, you know, we looked at, like in Roden's lab, we looked at, I think it was like 16 heads or something, and we found one that wasn't in the subarachnoid space. So it's not a guarantee, but almost always. And just below it is this thick dural ring here. Remember, as I said, there's two layers of dura. There's the outside layer, which is really, really thick, and then there's an inside layer that's thin and not always contiguous. So this is the outside layer, and it's very, very thick. It also has a name besides the thick dural ring. What's the other name for it? A neurosurgeon. Pardon? It's actually named after a neurosurgeon. Pernesky. So it's also known as Pernesky's ring. Okay. Now, if you look here, so there's this glistening area. This is a thin layer of dura, and it's surrounding these cranial nerves. This thin layer of dura separates part of the internal carotid artery as the anterior bend comes up and penetrates through Pernesky's ring. And this area here is technically the extradural, extracavernous carotid. So there's a segment. And we don't typically do this anymore, talk about aneurysms in this way, but there are a number of aneurysms when I was a resident would be located right in this location. And we coil a lot of these now because we can't tell whether they're past the dural ring in the subarachnoid space or not. And what we used to call them Now we call them like superior hypophyseal aneurysms or, anterior or internal carotid aneurysms. But the old term here was carotid cave aneurysms. Okay, and the carotid cave is right here. Okay. Now,
John, do you use the optic stratus landmark for your versus extradural?
no, I haven't used that. I don't know. I mean, that would be not a bad idea because the optic strut is very close to the Pernesky's ring, but it's not an absolute. We always have this when they're right there. It's and I tell you, the worst case scenario, and I've been there a few times. The worst case scenario is dealing with an aneurysm operatively, not endovascularly, and finding out that it's not in the subarachnoid space, and then have made it into the subarachnoid space. Now you've taken an aneurysm not so dangerous and made it very dangerous. And so so for all those kinds of aneurysms, I think where it's not clear whether they're in the subarachnoid space, really shouldn't operate on them these days with all the stuff the endovascular surgeons can do. Why bring that patient to more risk? I think surgery there is more risky. All right. So here's the third cranial nerve running up into the lateral wall of the cavernous sinus with the trochlear nerve, and the first division of the trigeminal nerve with Meckel's cave. Now, landmark, very important landmark for cavernous sinus surgery. Fourth nerve, right? Lateral wall, V1. Petrus ridge. Okay? What is that triangle called? Parkinson's triangle. Only triangle you really need to know. Now, when I was in training, I trained with Vinko Dolans. So Vinko, he got into this thing. There's all these triangles of the cavernous sinus. There's 10 triangles. Guys, there's 10 triangles. Okay? And he would go through and say why all these are important, right? And then there's a guy named Taka Fukushima, who some of you may know. And Taka always has to be, number one. And Taka says, oh no, there is 12 triangles. And I would go to skull-based meetings, and I would hear these two guys basically fairly vocal expressing how there was 10 versus 12 triangles, okay? And there would be an hour discussion about whether there's 10 or 12 triangles. It's not important. Who cares? The only triangle that really makes any difference in surgery is Parkinson's triangle, okay? By Dwight Parkinson from University of Chicago. Why is that important? He was very much into fistulas. He was treating fistulas in those days. And he developed this anatomy, and he found Parkinson's triangle. The reason why that's important is that's how you find the sixth nerve. The sixth nerve is in Parkinson's triangle. It tends to stay just in the back of the triangle, and the sixth nerve runs up over the horizontal segment of the internal carotid, and typically is just under V1. But when you're dealing with surgery in there, and you got something like Schwann-Ohm or something, if you get down towards the Meckel's cave, the trigeminal ganglion, you find V1 and you know where 4 is, you're pretty close to 6 and you know where you are. Okay, and that's how you find the sixth nerve. All right, you got a meningioma, soft meningioma, or something, you're in the cavernous sinus or pituitary tumor. That's how you find the sixth nerve. Okay, before it finds you. All right. If we go a little bit more lateral here again, we can see the second division of the trigeminal nerve going through the foramen rotundum, the third division going through the foramen ovale, and next here is the foramen spinosum where the meningeal artery is. Just a few millimeters, it's actually about 7 millimeters, just a few millimeters from the foramen spinosum is where the petrous carotid is. And in about 30% of the time, there's no bone there. There's just the carotid there. So if you go extradurally, there's the petrous carotid. It's kind of an important landmark. We like to find it before it finds us. And running just over the top of it is the greater superficial petrosal nerve. Okay, here we've drilled it out here. Okay. Another photo here, just showing. Here's a foramen ovale. Foramen spinosum is just right next to it. Typically, when we're doing cavernous sinus surgery or a middle fossa approach, we take that artery because it tethers our extradural dissection, and we can peel the outer layer off and never see the temporal lobe and just see the trigeminal nerve. And we come along and we can find the greater superficial petrosal nerve, which we can follow back to the IC if we're doing an acoustic, but it also helps us find where the petrous carotid is. Okay, if we cut the trigeminal nerve and we look, we can begin to see what's inside the cavernous sinus, and you can see the sixth nerve running up underneath V1. And if we take it out, we can see the sympathetic fibers here that run along the internal carotid, jump onto 6, then jump onto B1, and ultimately go to the ciliary ganglion, which I showed you earlier. Okay, right here. Here's the meningohypophyseal trunk, just at the posterior bend before it becomes the horizontal segment. And this is the anterior inferior lateral cavernous sinus artery, which supplies most of the blood supply to the cranial nerves within the cavernous sinus. Okay. Just another diagram showing a cartoon of this with the meningohypophyseal trunk becoming the inferior hypophyseal artery, the dorsal meningeal artery, and the artery of Bursinoni castenary, right here, also known as the tentorial artery. And you can see that here. Okay. Okay. Oh, one other thing. Here's the 6th nerve here in the subarachnoid space. Here's the Dorello's canal. Can you guys see the gap here? So it comes up, goes in through the labia dura, and then comes in. Okay. Where? Here? Yes, that is. Yeah. Okay, and just another picture of that, just to demonstrate that here the 7th and 8th nerve are really very close to the cavernous sinus, 9, 10, 11, just below that. I think for the sake of time, what we'll do is we will talk about surgical approaches to the orbital apex and cavernous sinus on another date. And that, because we're running out of time. But that's the anatomy lesson for today. And the next time we do it, we'll assume that you all understand your anatomy, and then we'll move on to how to get there. Okay? Just because we ran out of time.